Good afternoon, everybody. So thanks again for joining us for our series, our webinar series from the RTSO. Today we're going to talk about moral injury in healthcare providers. Oh my God, what the heck did I do? So sorry on that title screen. Oh my gosh. Anyway, I didn't even catch that. We'll just scrap that, go past that quickly. So I want to say welcome from the RTSO board. I also want to communicate a bit of a change that's happening in terms of the board, and just do a quick explanation around this. So our board members, as you can see on the screen, Kelly Hassel is now going to be, as of today, the president, and I will become the past president. And this is, and I'm not going to go into detail, but this is due just to a conflict with, or a perceived conflict with my full-time role in my job. Kelly and I have worked this through. She's been absolutely fantastic. I am going to support her in the background. So here's my saying: behind every great woman, there's another great woman.
Exactly.
So I'll be the great woman behind Kelly, which is fine with me. So in addition, we also have our editor-in-chief of Airways, Shauna McDonald, Sue Martin, our treasurer, and then we have Wendy, Sylvia, Farzad, and Gino, all directors at large, all with great jobs, all doing fantastic work to help supporting everything we're all doing. And then our non-voting members include Nancy, Garvey, Mika Nonioma, I never say her name right, Steve Buziak, Tina Yan, Shirley Quach, and Greg Donde. And again, great job in what they're doing and supporting the RTs of Ontario in the various committee work. So just thanks to everybody for that. Oh, just a quick thank you to all the RTs across the province on what you do every day. We do appreciate it. And I was just saying today, actually, in terms of discussing, I actually just had a call with the CSRT and the CRTO, and just wanted to, I again said thank you to them, because without all of you, without the CSRT, without the CRTO, without some of the support we got from physicians and different people across this province, we would not have been included, in my opinion, in the pandemic pay, because we were kind of left out at the beginning. But because of all our lobbying and all of our efforts and our great communications that we did across this province, this is a good result, and just shows if we unite together, we can accomplish some really cool things and really great things. So I just want to say thank you to everybody. All right, after that. So now I just want to introduce Margaret. Kelly, did you want to say anything before I keep going? Actually, Fatima is going to introduce Margaret.
Oh, I also just wanted to add in that we are very fortunate. We are going to be adding a secretary to our board shortly. So we have just received some confirmation. So you'll see some information about that coming out shortly. So Megan McFarland is going to be joining us as secretary, and we have Fatima, who's going to be in training to become our next project advisor. So thank you so much for that. And here's Fatima to introduce Margaret.
Super, thank you. So Margaret McKinnon is the Homewood Chair in Mental Health and Trauma. She's an associate professor at McMaster University and a scientist at the Homewood Research Institute. She is also a psychologist in the Mood Disorders program here at St. Joseph's Healthcare Hamilton. Her work as the Homewood Chair in Mental Health and Trauma focuses to advance the clinical practice outcomes and treatment of post-traumatic stress disorder and related illness on a national level. Margaret has very kindly agreed to collaborate with the RTSO to develop a provincial study on PTSD and related illness in respiratory therapists. This work will resume following our current pandemic. Despite her very busy schedule, she's agreed to speak to us today. And with that, I thank you, and we'll let Margaret take over.
Thanks so much, Fatima. It's really, I have to say, it's an honor to be here today, and I mean that in the strongest possible terms. I come from a first responder and healthcare family, and I'm very aware of the challenges that many of you are facing right now. And I really want to salute respiratory therapists who I think have often
been under-recognized and the light has not been shone upon your profession in the way that it should be. And I see some hope in that, but I think certainly the decisions that were initially released this weekend were incredibly distressing. And I'm very glad that that situation changed. So thank you again for having me. And in all honesty, I just want to say I'm very honored to be here today. What I'd like to do, I'm going to turn off my camera and I've just let you know that my dog is in the room and she gets quite upset, so she may jump on me at any point. So I apologize for that. So I'm going to talk today about moral injury, and I want to start by giving a framework around that. Moral injury essentially is when we are asked to do or witness or are involved in actions that violate our own sense of morals, our values, our ethics. And we certainly know that with the COVID-19 pandemic has brought some very challenging situations to those of us working in healthcare. We know that information is changing by the moment, that we're being asked to practice in ways that we don't have an understanding of or knowledge of, and it's very challenging. I'm going to bring some specific examples to bear around that. The second facet of moral injury, which I think this group experienced over the weekend, is not being supported by adequately or not being recognized adequately by individuals who have an obligation morally, ethically, legally to support you. So a good example of that would be the pandemic pay, where there is an expectation that when healthcare workers put their lives on the line, that they should be supported. And I think what happened over the weekend is a classic example of the sense of betrayal or anger people may feel when they're not adequately supported by those who should do so. And so I'm going to come back to that point throughout the talk. I was asked, I do this talk a lot, and I was asked by the government just to add a little disclaimer that the views that are being expressed reflect the most current information we have. And we know within the context of COVID-19, things change minute by minute. So I, for example, have sent emails to people that I work with some sort of decisions or instructions, and the minute I hit the send button, everything has changed. And so I just want to say that what I'm talking about today is the best information we have at the moment, but it could change moment to moment. I think it's also important for us just to start with the framework of thinking about the COVID-19 situation. It's really an unprecedented situation. We've never faced anything like this. Many of us are very familiar through our work in healthcare with life or death situations, but the pace and the scope of this is far greater in many regions and parts of the province and parts of the country than we ever have experienced before, even with SARS, which I know was incredibly challenging for your profession. We also know that no one can prepare fully for a pandemic, but that said, there are lessons that were learned from MERS and from SARS that I think probably could have been applied to a greater extent around the current pandemic situation. But people did make risk calculations with the best of intentions, and where we are right now is certainly not the result of, I think, people trying to make the wrong decisions around PPE or trying to make the wrong decisions about preparedness. I think it was a risk calculation that unfortunately we need to learn from. We also know that the current situation with COVID-19 is a marathon and it's not a sprint. We, for better or for worse, have a long road ahead of us, and sometimes the slower we go, we stop, we take time for a break, we take time to think and to regroup and to come together. That's the mentality of a marathon, where we go slowly so that we can reach the end in a better and more prepared way, and not in a sprint where we exert all of our energy now and we have nothing left over for later. One thing that has certainly been very apparent to me as a psychologist is that we're all in this together. So I think our healthcare professions are coming together in ways that we haven't before. I was talking to Kelly and Fatima and Sue just before this talk, and they were talking about the support that they're receiving from physicians, from nurses, from our hospital president here at St. Joe's, really coming together to support one another and also to recognize the profession of respiratory therapy. I think we're in this together and we're learning together. And I hope that when we come out on the other side of this, we're all brought closer together permanently as a result of this. We also know that around many ethical challenges, there are no right or wrong answers. I think that's one of the first things we learned in our healthcare professional training, is that Many of the situations that we're asked to deal with are not black or white, they're gray. We have to find that middle ground of what the right decision is or the right answer is. And sometimes, unfortunately, that could be the decision between what's wrong or wronger. So a less negative outcome versus a very negative outcome. And that, of course, is very challenging for us in the healthcare professions and also for public safety personnel like firefighters, paramedics, dispatchers, police, who we work closely with and often face very similar challenges. And I think on balance, most everyone is really trying to do their best. And when we look at our colleagues and we look at our friends and our leaders, on average, I think most of us are really trying to do our very best, but we're caught in a situation where even when we do our best, when we offer the best possible treatments that we have in our hands right now, it may not be enough. And that's incredibly challenging when you've trained as a healthcare professional, you know about evidence-based care, you know what works in most situations, and we're now in the face of a virus that's we don't have the answers for, and we're just trying to do our best, the best that we possibly can. When we think about healthcare workers and public safety personnel, I think it's really important, and around respiratory therapists, to think that we're dedicated to serving Canadians. I think people work very long hours, certainly in your society here, long hours well beyond what they're paid for, well beyond what's recognized, because we all have a dedication to service. We all came here to serve. We are prepared, so we come to our jobs with a large amount of knowledge and experience on average, and that preparedness allows us to do our work. Here again, we're in a situation where even as best prepared as we are, we don't always have the answers or the equipment that we need to do the work that we need to do. We know that we're competent and we know that we're professional, and we're going to do the very best that we can for our patients and for our community. But we are faced right now with some wicked problems. And when I talk about wicked problems, I really mean that decision between wrong and wronger. How do we make the least negative decision to avoid the worst possible decision? And we're also masters of making a decision right on the spot, really tough decisions that we have to make in the moment, because that's what we're being asked to do. And again, that can be challenging. I realize as well I don't have the full slideshow on. Sorry, everybody. Sorry. Sorry about that. So what I want to come to around this notion of wicked problems and making decisions between wrong and wronger is again that notion of moral injury. So this is a particular trauma that might have psychological, existential, behavioral, or moral issues that arise because we're being asked sometimes to violate what we might consider to be deep moral beliefs that we hold ourselves, or we may feel that other trusted individuals who we expect to support us haven't supported us in the way that we want to. My dad, when I was little, was a fire captain, and when he will often talk about having to make the decision between sending in firefighters to a building that's about to collapse or leaving a family trapped inside. And I can't even imagine how painful that sort of decision would be made to make, and how I know even now, 40 years later, he still lives with that decision. And I think that is, again, that violating your deep sense that we're going to go into any situation and help. That's how we've been trained. That's what we've been asked to do. And sometimes we have to make those very, very difficult decisions. Also, again, with the example from this weekend of respiratory therapists being excluded from the pandemic pay, that is a really, I think many people, I'm sure on this call and this webinar, experience that as a betrayal. And I'm so glad that advocacy resulted in a reversal of that decision. So, oops. I want to give you an example. So we do a lot of work with the military and with the first responder community. And we often interview people around moral injury. And what many people say is that moral injury is the signature wound of service. We're all here to give service, but we make decisions that often challenge our souls. And so many military members describe moral injury as a bruise upon the soul. And I think this veteran that we interviewed a couple of years ago really described this very eloquently. So we asked, and sorry, Stella's getting very upset, sorry about that. What would it be like if people were to see inside of you? And the veteran himself said, "It feels really scary. I feel like they're going to see a kind of stain upon my soul. I feel a sense of shame about being in the situation in Vietnam. And I also feel shame about some of the things that I witnessed and I couldn't do anything about. Case in point, watching idly while they threw a grenade in a hole with a guy and knowing full well what the outcome of that was going to be." Obviously, our example here, I'm just going to give Sally her ball, sorry. Our examples in healthcare are not as extreme as this example, but certainly some of the decisions that we're asked to make, we may feel that we do have a stain upon our soul, and that others who haven't had similar experiences and who haven't had to make the difficult decisions that we do in healthcare may not be able to understand. We often hear from first responders that, for one thing, they're in situations that are incredibly difficult during the day, and they drive home and suddenly they're expected to transition into a new role. So for example, leaving the hospital after you've lost a patient and going home and walking in the door when suddenly you're a mother, a wife, partner, and others in your family may not necessarily be able to understand or appreciate that experience. If I move suddenly, it's Stella pulling me across the floor, so sorry. And so this is what this veteran said. He said, "I mean, if somebody found out about me, they might run. Previously, I'd been in a PTSD group, and there was one of the other guys in the group who said that when he looked into the eyes of a person who hadn't been in Vietnam, it was kind of looking into the eyes of a baby. They were just innocent. And I have that same experience. Part of me wishes that I could get that innocence back, and that's something I wish really often." And I think for those of us who have seen the curtain pulled up around healthcare and who have seen the difficult choices that are made, who have watched, I know in your profession, people die a very, very difficult death, it's difficult for others who haven't had that experience to understand. And I think sometimes we feel isolated from the broader community because we've had those experiences. I think the antidote to that in part is how we come together as healthcare professionals to talk about our experiences and support one another. But it can cause a disconnect with others who don't have that experience, like family members. I think there's also a profound disconnect right now as well between the healthcare community and individuals who are violating requests to engage in social distancing. It's incredibly frustrating, I know, for all of us to see people who don't follow those directives and then bring risk onto us as healthcare professionals, but also onto our families, because if we become transmitted or become infected, we also have to worry about the risk to our family members as well. And that's a very, very difficult thing to hold, and to know that other people may be doing things that don't help us in our mission and help to protect us as well. And I remember this is an interview that we did with someone who was at Homewood Health Center in Guelph. We were interviewing first responders about their experiences. And he talked about moral injury, and he said, it's those moral injuries. It's not just one trauma. I liken it to, it's like giving that little rock in your shoe where you can walk 10 steps and kick it out, and it's okay. And 10 more steps, you get another pebble in your shoe. You do that over 10 years. You walk around with those pebbles in your shoes. It's going to irritate you after a while. And that's what I find is my experience. That's what kills me. And some of the big things are the straw that breaks the camel's back, but sometimes it's just the small. And I really think about that within what's happening with COVID-19, that I think this is bringing to mind some of the previous experiences that we've had. I know I've talked to members of your professions, a respiratory therapist has said, this is really bringing back really difficult memories, for example, of SARS and MERS, and some of the experiences had then, and how that cumulative burden, how the past is informing how we feel right now, but also how all these experiences can pile up, and it could be a small thing that in the end sets us that really has difficult consequences from our mental health, and maybe the thing that causes us to break. So I don't want to sound all gloom and doom, because I am going to talk about some of the things that we can do around this to prevent this from happening. But I think it is important to reflect upon the experience that this patient with PTSD, who was a first responder, talked about so eloquently. So we certainly know at the present moment, the context in healthcare has really evolved and changed. In the face of COVID-19, again, as we talked about, information is constantly changing. We make decisions that within minutes may be questioned, or maybe we may have new information that comes to light within those minutes where we have to reverse course and do something different. There's reports coming out of some hospitals around whether the use of certain equipment is beneficial or not beneficial, and then we may find out a week later that what we did was our best effort the week before maybe wasn't the best thing to do in that situation. We don't know. And I think COVID-19 really challenges all that education and experience that we have in thinking that we know what to do, and then finding a situation where we have an unknown enemy, essentially, or an enemy that really comes at us in a way that we can't predict or control. And I think that is incredibly challenging for all of us in healthcare. So I want to say here that we know very clearly that moral injury extends to the healthcare community. We know that, like first responders and military members, we're also asked to make those decisions between wrong and wronger. And we may also experience that sense of betrayal or anger that comes when we feel that we aren't being adequately supported by our leadership, by the government, and by the community who's doing things that could put our health at risk. And I really want to talk about that in a bit more detail, and then we'll have the opportunity also to ask some questions and to talk together. So we know that there are a number of risk factors for developing moral injury, and I think many of them apply very clearly to the current situation. So we see with COVID-19 that there is loss of life in many cases to the most vulnerable among us. So to people who live or older people who live in nursing homes is a very good example of that, where these are people that we respect very deeply, and that we want to protect, and in this case they're losing their lives, and sometimes it seems like in a way that wasn't necessary, and that can really lead to a sense of moral injury. It can also be the case that leaders are not perceived to take responsibility for the event, and certainly when we look at shortages of personal protective equipment across the country, I think many of us have had the response that people need to step up and take responsibility for that and do everything that they can to make sure that adequate PPE, for example, is provided. I know from talking as well to my healthcare colleagues that many of us also feel that at times our leaders are perceived as unsupportive of staff. And I know myself, I have a history of PTSD, and I do, I certainly find this event very triggering. And I really expect that those that I bring that information to will be supportive. And I know some of us, when we disclose those sort of things, we don't always get the response that we're hoping for, and that can be very challenging. As well, those of us in healthcare may feel unaware, unprepared for the emotional or psychological consequences of decisions. So for example, making a decision to leave children inside of a house because the building will collapse within minutes and those who go in will also be killed. That really, it's hard to be prepared for that. It's hard to know what impact that will have across the course of your lifetime. And I think there are similar examples happening now in COVID-19. We also know that what we're facing within our profession is happening within a broader context. So, for example, we may be isolated from family members and from friends. We're not able to see them physically. Many people are facing within their households economic challenges right now as well. And then being asked to go into the hospital or into the clinic and being asked to do incredibly difficult things. And there's a whole other context behind all that that's also in your head. We know that with the single greatest predictor of whether or not someone has PTSD after they experience a traumatic event, it's how much social support that they have. And I know within your profession, it seems to be a very cohesive group that's working together, certainly is seen in this society. But as well, there are other sources of social support that we maybe not have the same access to right now when we're facing a traumatic time. So that might be going for lunch with a friend, spending time with family members, and really accessing our supports that we need so critically to help us through difficult times. And I think that is a challenge. There is a rule in trauma as well. It's called the 90-10 rule. And what that means is that essentially 10% of what we're thinking about or experiencing right now relates to the present moment. But another 90% comes from the past and our past experiences. And we know we've done a lot of work around moral injury in my group, and we look at what are some of the things that make us more vulnerable to a moral injury. And one of those things is a history of childhood emotional abuse. So individuals who grow up within households where they didn't have control over themselves or their body, they were told that they were dirty or shameful, some of that can come to mind in situations like this, where again, we're being asked to do things where we don't have control, where we feel that others are judging us or making comments about us that can be really hurtful, and they can also bring to mind past experiences as well, and that can make it even more difficult to face those challenges. As well, many of us have a great deal of difficulty, and I count myself among these individuals, identifying what our emotions are and what's driving them. So a good example of that is anger, where anger often comes from a secondary emotion. So another emotion that underlies that. A good example of that would be a sense of betrayal. So we may experience heightened levels of anger or irritability, but that may come from another emotion that underlies that, which could be a sense of betrayal. And that could be driving the anger. And it's often very helpful to be able to identify what that underlying emotion is to help us get a hold of or get a handle on the larger emotion that we're experiencing. So betrayal being linked to anger is one really prominent example, particularly around moral injury. So I worked a lot with Veterans Affairs Canada, the University of Alberta and the University of Western Ontario. And we gave this talk to the Canadian Institute for Public Safety Research and Training last week, which brought together first responders from across the country to talk about this topic. And we generated some examples of decisions between wrong and wronger, or situations where we may be facing a sense of anger or betrayal. And I just want to talk a little bit about what some of those situations might be. And maybe when we get to the chat function at the end, we can talk about how this relates to people who are watching the talk and some of the solutions that you may also come up with yourself or in a group to handle some of this. So I know for many people, there may be a sense that we're not doing enough for our colleagues. So for example, when someone falls ill or has symptoms of COVID-19 that they haven't been tested for and they need to go into self-quarantine, there may be a sense of guilt around those people who are still in the field. So those individuals who are still out carrying the workload when you can't be there. And that's really difficult because everyone knows why you're not there, and it's really important, and it's the best possible thing that you can do not to come in and potentially harm others. But it's also hard to think about our colleagues who are still there, who you may feel are carrying on your load, and you may be worried and concerned about them. There's also the notion of being served versus serving. And I think for all of us, we've chosen these professions because we really want to help. I think that underlies that notion of service doesn't just apply to military members or veterans or public safety personnel. It applies to us too. We're here to serve, and we're in a helping profession. And when we feel challenged, so for example, when we might be feeling stressed or anxious about what's going on, or feeling sad or depressed, we have created in many of our hospitals opportunities to come forward around these concerns and receive help. But sometimes we don't feel comfortable going to the front of the line and receiving the care that we need because we think about others who also need it, and that can be uncomfortable. We know too that I think for many of us, we have that experience right now where we're wearing our personal protective equipment. So for example, our masks, and our patients can't see our faces. And that is something I think that's really unusual for us. We're not used to that. And it can be, I think, really difficult for patients to have someone providing the most intimate of care, like ventilation, where they can't see the person's face. We've seen those examples coming out of the US at least, where healthcare providers are wearing their pictures on their PPE so that their patients can see who they are. And I think that's really difficult for us all to face. We're used to having that personal connection when we can look someone in the eye or use our whole face to provide care. And I just think that's an incredible challenge. I even find that interacting with colleagues, where I saw my former clinical supervisor yesterday. We're very good friends, and we couldn't see each other's faces fully, and we also couldn't give each other a hug. And I found that so difficult, not to be able to do the things that we would normally do to support one another. And I think that is a form of moral injury. It's a form of feeling that our deepest held beliefs, that we want to connect with others, that we want to provide comfort and care, and we can't do that in the way that we know to be best for others. I think it is also incredibly challenging to have to tell families right now that they can't be there with their loved ones. And that applies not just to people with COVID-19, but to also other people in hospital, where the majority of our hospitals right now are shut down to virtually everything but palliative care, where people are allowed to have visitors, or even in nursing homes as well, where we as individuals can't see our loved ones, but also we have to be the person who tells families that they can't go in. And particularly when someone is admitted with COVID-19 and the outcome is so uncertain, I think it's just incredibly challenging to have to turn a family away and say, I'm so sorry, but you can't be here. And that's best for you, and that's also best for the person who's coming in, who would want you to be protected. And I think that is a very challenging ethical and moral thing to have to do. As well, we know that when a unit goes into quarantine, or when there's an outbreak, individuals who would otherwise be discharged need to stay on the unit. And we've had that situation in mental health. I also work at the Homewood Health Center in Guelph as a researcher there, but I have clinical privileges there, and they have had cases where they've had patient outbreaks on addictions units where people have completed treatment, but unfortunately they need to stay in hospital another 14 days because of the outbreak being declared. And I think that, again, presents us with challenges morally and ethically. It's the right thing to do, but we may not feel very good about having to do it. We have been fortunate in the majority of cases here in Canada that we haven't had to deal necessarily with surge capacity. With surge capacities, although in some instances we have, and that can feel like having to make a decision between who lives and who dies. And there was a really good article that came out in the Journal of the American Medical Association a couple of weeks ago, and it talked about the Italian experience and having to make decisions about who would receive a ventilator and who wouldn't, and how tricky that can be. For example, making a decision between a young man in his 30s who has an uncertain cancer prognosis, or a woman in her 60s who's very healthy, but the decision needs to be made who gets the ventilator, which may assist in their survival. And that is incredibly, again, challenging. I know I keep using the word challenging, but it's because it is. We do certainly have guidelines now that have been developed provincially that help us in making those decisions, but it doesn't take away from the pain that comes around that. I hear this a lot, is that there is also a fear of being stigmatized. So, for example, sorry, I'm gonna have to just go and get Stella's ball. So, for example, there is being a healthcare worker and knowing that others may fear that you'll infect them. But even more so, what about when some of us do inevitably contract COVID-19, and how we may feel that others are judging us, that we didn't use our PPE adequately, that we made decisions outside of work that may have exposed us to more risk. And we don't want that to happen, but sometimes we may feel that that's the experience that we're having if we do contract COVID-19. And I think it's really important for that sympathetic, self-compassionate, as well as other compassionate view to be adopted here. As well, you know, it is challenging as well that we often, when there is an infection in a healthcare worker, for confidentiality reasons, the identity of that healthcare worker is not released, or it's released within circles of who needs to know, and not out to people who are either don't need to know or perceive not to need to know. And I think that has been a huge challenge for many of us as well, because wanting to know that information and thinking expecting that that will keep us safer has been a huge, huge challenge. And I'm hearing about that across the province and across the country from people that I've been speaking to around this. And then what do we do when I'm here to serve and to protect you and you can't be bothered to follow the isolation guidelines? What do I do with my anger at you? And I think that's a direct quote, and I think it's a really important one. So when we see pictures, for example, on beaches of people on the beach over the past weekend, when we go out in our communities and we see groups together, large groups of individuals, it is incredibly challenging knowing that the risks that poses to the wider community, to healthcare workers, and then by extension to healthcare workers' families. I think when we think again about anger as a secondary emotion, I think that what underlays part of that is again that sense of betrayal, that I'm putting my life on the line for you, so please help me, and not putting us, the community, at greater risk, which will result in more patients coming in, but also putting my health at risk because those patients are coming in more and more. Then I think here fundamentally, and this is a picture of a healthcare worker who's at home self-isolating within his home because he's so worried about bringing the virus home. And so we really, I think some of us really do struggle with that idea of putting our family at risk. I, for example, won't let my husband in my car because I consider it dirty now. You know, you just don't know. And so I think it's that we take on the risk not only to ourselves, but we really worry, I think, also about bringing something deadly home to our families. And that, again, is very, very difficult to live with. And so we come back to as well the fear that we've made a mistake, because again, we're up against something that's unknown. Information is constantly changing. This virus seems to have different forms that we can't get a handle on, and also around the idea that it affects different parts of the body. We can't predict that in a reliable way. So when we make decisions as healthcare providers, I think we really do worry about, did I make the wrong call? You know, with the information that I have available, I'm doing the best that I can, but was that the wrong call? And not having no way of really knowing the answer to that. I mean, it's not the wrong call, so to speak. It's more that making the decision that you could in that moment, and what is the outcome of that? And sometimes we don't even know. I think when patients pass away and we don't even know the outcomes, or we don't know why, our patients come into ER, for example, and they go off to care and we don't know what the outcomes are. That's challenging. I think finally that question of, does my leadership have my back? And that's what we hear constantly within the healthcare community, is the people that are there as administrators and leaders, are the decisions that they're making, do we trust in those? Do we feel that they're the right decisions? And if we're uncomfortable, how do we come forward without consequence? And again, these are questions I think that we're all wrestling with within the healthcare community. Oops. So we've talked a lot now about what some of the potential moral dilemmas may be that we're facing within healthcare right now, how some of the decisions that others make on our behalf may lead us to feel angry or to have a sense of betrayal. But what can we do to help? How can we bring some hope to this situation? And what are some of the antidotes to the situation that we're currently facing? So this was a really interesting study that came out very recently. It was a survey of healthcare workers in the US around COVID-19. And these are some of the things that people were asking for as healthcare workers that they need to have from one another and also from their leadership. So the first is to see me for who I am. So not just as a healthcare worker in this moment, but someone who has a family, who has risk factors such as a previous history of depression or PTSD, someone who is facing financial difficulties at home because a partner has lost a job, for example. See me for who I am and for the whole of me, and acknowledge that. Protect me. So provide me with the personal protective equipment and other tools that I need at my disposal right now to be able to do the job that I am and also that I need to do, but also that will help to keep me safe. Prepare me. So tell me all of the available information that you have. If, for example, you are making a decision about how to dispense personal protective information, well, tell me what you know as well. Help me to participate in the decision making. If I'm going into work today and there's new information about COVID-19, make sure I know it, prepare me to do my job. Then support me, provide me with the supports that I need. So a good example is access to mental health resources, access even to meals if I'm working 24 hours a day or very long shifts. Provide for me, give me the support that I need during this time. And finally, if I do in fact, as a result of the risk factors that we all face, if I do end up having COVID-19 myself, or if a family member does, care for me. So healthcare workers need to know that if something does happen, and sadly does happen, that when that happens, that we won't be stigmatized, that others won't judge us, and that we'll have the supports that we need. So support for our family, support for us as individuals, and access to healthcare. And I think that's tremendously, tremendously important. I can remember years ago at St. Joe's, we were having some issues around violence on our inpatient units. And I think part of the antidote to that, in part I always thought, was to acknowledge the risk factors, to acknowledge that there was a possibility for harm, but also to say that we have your back. If something happens, we will support and we will help you to get through this. And I think that's what first responders hear all the time from their communities, that we have your back. There's that notion of being brothers and sisters in this together, and that care will be provided if something happens. Our own group has thought quite a bit around this as well, and we think a lot about include me, so to include others in decision making. So when a difficult decision has to be made, not that it's just top down, but that everyone is included in the decision making. So if we need to make a decision, for example, around the use of ventilators, I think that everyone needs to have a voice in that, to think about what we're going to do. So be that physicians, respiratory therapists, and other care providers, include me in the decision making. And as I said, I think already before, tell me what you know, and tell it to me as soon as you know it, so that I can go into my job as best prepared as I possibly can be to face the current situation. And we certainly know that a really normal reaction under conditions of stress is to look for an explanation by blaming others. And that can be others in leadership, others who are working directly with us. And that's challenging because in the current situation, we just have a lack of information. We have an enemy, essentially, that is unknown. And how do we come together in this situation, all of us together, to make those decisions together? And often there is that hindsight bias that, we look back from where we are right now and think about decisions that others have made with the benefit of the information we currently have, but it's difficult. I often think of COVID-19 as a fog of war. So we're in that fog right now where decision making by us as individuals, by us when we're treating our patients, as well as by others who have to make decisions, it really is that fog of war where we don't really know all the information, yet we have to make decisions. So I think that hindsight bias can sometimes get us in trouble when we think about what we know currently, but we're not able to really think about what the situation was when the decision was made at that time. I work a lot, as I had said, with the military, and we've been working on a paper right now where we think about COVID-19 and how the principles of battle and war really apply here. And this is so there's 3 colonels on this paper, which is a very interesting group to work with. I get a lot of orders. But this is what they came up with around what military principles do they think apply to the current situation, and how can that help us to prevent some of the moral injury that many of us are experiencing right now. So one thing that these colonels said was that we need to listen respectfully to the concerns of what they call subordinates, to the interesting use of language, but it really is how it's framed in the military. So listening respectfully to everyone, be that the PSW on the unit, the RPN, the nurse, whoever it may be, hearing everyone's concerns. That we need to remain positive, but we don't need to be overly optimistic. So, for example, when people march into war, it is a situation where we know there will be casualties, where we know that people, as a result of their service, will develop PTSD and depression. And we don't try to sugarcoat or hide that. We're positive and we maintain optimism, but we also are realistic about the challenges that are being faced. It's really important for people in leadership positions as well to reflect the values of the individuals that they're leading. So not just individual or personal values, but the values of the community. And I really get that sense from this society that the leadership of the society is really trying to reflect what they hear back from the respiratory therapy community and to bring that into action. So reflecting the values of all of us. We also really do need to recognize that, like in combat, the risks of COVID-19 are not evenly distributed. And we know that individuals like yourselves, like respiratory therapists and healthcare workers, we're on the front line and we are at risk, and we are at greater risk than our family members who are not. And we're at greater risk as well than our communities, our friends, our neighbors who are not going in every day to the hospital. I know when I left last night, I was just so sad, and I was thinking about everything that was happening. And I thought, you know, it's really difficult unless you're here to know what this is, and to know what that sense of risk is. So that is as well challenging. We also know that the most vulnerable individuals in society are at the greatest risk. And so we think, for example, of what's happened in long-term care homes and what's happening with the homeless, people who live in shelters, as well as people with mental health and substance use challenges who are living in group homes right now. And, you know, we in many ways are privileged that we have a profession and we have jobs and we are able to go home and provide for our families to maintain space and physical distancing. But for other people in society, they don't have that privilege that we have. And it is challenging to think about the risks that they also face. And I think that does give rise as well to a sense that our moral and our ethical values are being challenged. To hear about older adults in nursing homes and some of the conditions there, again, is just incredibly hard to hear. We need to care deeply as well about everyone that we lead. And the notion in the military, and I really deeply believe this, and I think it's the same that we have, I hope, at least in our healthcare community, is that no one is expendable and no one can be left behind. And I think that that is tremendously important. I feel that in COVID-19 at times it has felt like healthcare workers are being marched in, and I think it can feel like they're being treated as expendable. And it would not surprise me at all if some people on the call had this sense that they were being treated as expendable. And I think we need to really rally around that and think about how we create conditions for ourselves and others where no one is expendable and no one can be left behind. It's really important as well for leaders to accept personal blame for failures, even in cases where it's not always your fault. So really being able to say that, you know, we're a group, we took on a decision, we made a decision here. It may not have been the best decision, but it was based on the information that we had at that time. And I accept responsibility for that. That's a challenge for a leader. And that's something that I think many people in leadership positions struggle to accept blame, even when it was potentially their fault. It's also really important to attribute successes to those that you lead. So we need to attribute success not only to ourselves, but to those around us, as a community of healthcare workers, as respiratory therapists, attributing the successes that are being had right now to everyone and not just necessarily to individuals. So this is advice that came from a really good colleague and friend, Alex Hebert, and she is a former Lieutenant Colonel in the Canadian military who's now the Chief Psychiatrist at Veterans Affairs Canada. And these are some of the things that she came up with to talk about what can help us when we do experience events or situations that could lead to moral injury. So she talks about how we need to gird ourselves individually and collectively by preparing as much as we can, but also recognizing and not sugarcoating the challenges that we're about to face or that we are facing right now in the moment. I think it's important as well to have regular team discussions, for example, huddles that will allow us to assist in decision making. So when we need to make a challenging decision between wrong and wronger, to discuss that as a team. And then also to come back together to discuss and debrief when we experience exposure to morally injurious events. So a good example of that would be watching someone pass away where their children or their partner is not able to come and see them and be with them. And I think when I read as well in reports, or when I talk to people and they talk about how hard that was for them to be the person holding the tablet when the person says goodbye to their family, for example, it's good for us to come together and talk about that and the challenges that it faces. I think as well, being able to seek and also to expect guidance around moral and ethical dilemmas. So we do have decision-making frameworks that are being that have been adopted, for example, around the use of ventilators. But we should expect our leaders to be able to provide guidance and support around making these decisions. One thing that we certainly know about exposure to trauma and situations that create PTSD is that often when we're facing challenges and trauma, the automatic response in many cases is to avoid. So to step out of the situation, to step away from friends and family members, and to self-isolate with the sense that we're self-protecting. But in fact, what we know, as I said earlier, is that social support is the single biggest thing that we know will help us get through this. So it's incredibly important to keep connected and not to avoid, and thereby maintain relationships with close friends, with family members, with our colleagues. Because that avoidance in the end, although it's painful in the moment to maybe pick up the phone or maybe to reach out, in the end, it's going to get you to that support that you need. I think we all also need to self-monitor, to think through how experiences affect you, not just now, but how they affected you in the past, to recognize when you feel that your values are being compromised and when you're having struggles. And this is often an important distinction used in the military, to distinguish who you are from what you did. So often, we are asked to do things that we may not feel comfortable with. So for example, having to hold the tablet and say goodbye. And I think it's important to recognize that under the best possible situations, that wouldn't be our ideal choice as an individual, but we had to do it in that moment. To focus efforts on what is within your power and to accept situations you cannot change. And this is the fundamental principle, for example, of AA, that we need to be able to accept that there are situations where we cannot change them, and we need to actually focus our efforts on what we can do within our power. As I talked about earlier, again, this is a marathon and not a sprint. When we take time for self-care, when we take times for breaks, when we go more slowly, we're actually preparing ourselves for what's ahead. So taking those short breaks in the end can get us to where we want to be quicker than if we try to do everything right in the moment and rush in and expend all of ourselves and have nothing left. It's also important in situations that are morally and ethically challenging to foster flexible thinking. So to take the time to sit down, if possible, and I recognize in many, many situations it's not possible to take this time, but where possible to sit down and think together what some of the possible options are and what some of the possibilities are. And when something does happen that is not the outcome we wanted, it's really important to think sometimes about what was the greater harm that was avoided. So there was something not wrong, but something difficult that happened. But what even more negative consequence did that avoid? We talk a lot in psychology about emotional regulation. So really thinking it, for example, about things in the past that have helped you when you feel overwhelmed. For many people, that could be things like yoga, mindfulness, going for a run, calling someone, having a hot bath, having a cup of tea, really thinking about what has helped you in the past and can you take the time now to do what's helped you before with the hope that it will help you now. And sometimes I think that it sounds like common sense, but it is common sense. I think it's just sometimes we need to do that for ourselves and take the time to reflect back on that, and then also take that next step to use those strategies. There are certainly as well stress management skills and routines that can be developed as well. One thing that many people face right now during COVID-19, and I think it applies less to those of us who go into the hospital still, but making that boundary between work and home. So right now, I don't think I've ever worked this hard in my life. I can honestly say that it's 16, 17-hour days right now, and it's been that way for the past 8 weeks or 7 weeks. But how do we make a boundary between the work that we need to do and our home life and our personal life? And that's far easier said than done, but I think it is something to think about. So for example, setting regular times where you're at work, your head's in your work, you might come home and allow yourself half an hour, but then trying to say, I'm going to use some form of distraction right now to try to get my mind off that. And that could be, again, that going for a walk, doing something you enjoy, like watching a movie, talking to someone, but really consciously saying, I'm going to give myself a break from this. I deserve a break and I need a break. And I'm going to use strategies that will help me to do that. It's really important as well to seek assistance when it's needed. So for example, to reach out for peer support. In the military, it's often chaplaincy that's involved in this, employer assistance programs, and then mental health services that are available to you through the community or through the hospitals where you serve. Again, really seeking out that assistance. So I'm going to talk in a few minutes about how that might happen and when we might know that we need to take that pause and reach out for help. Really important as well that we advance what we call public spirited behavior. So surviving COVID-19 really will rely upon our behavior, both as individuals, but also collectively. And we are credible voices for the public good, and we have influence. So we need to be able to practice crisis communication. So communication that's timely, that's honest, that's credible, that's respectful, that is clear, and also is an optimistic direction. We also need to come together as a community. So again, going back to what I talked about a few minutes ago, to foster that strong group identity that you as respiratory therapists have, in part through this society, and also cohesion. So being able to check in regularly or have huddles with our direct colleagues, but also with leaders, but also with the wider community. So not just respiratory therapy, but physicians, doctors, nurses, RPNs, PSWs, whoever it is within that context that we're experiencing this together, and we need to check in with one another and see how we're doing. We also have opportunities to encourage the public to follow the rules for all of us. And it's not that we want to shame others or engender a sense of guilt or shame in them, but I think we can empathize with how difficult it is for those who have to stay home, but also to share credible information, to talk about the elevated risks if they don't social distance, and really appeal to their pro-social selves. So saying, by staying home, you're helping to protect our most vulnerable. Good examples of that being older people who are in nursing homes, and really helping people that we can feel betrayed by or we feel who are doing things against our best interests, to help them appeal to that part of themselves that wants to help, that's pro-social. And that could be one way of doing it. And I think many of us now are using social media, and we're using that to foster pro-social activity. So again, not to, guilt or shame individuals or leaders, and I would say maybe even government, although sometimes they do need to be shamed, but helping them to look inside of themselves and to do the right thing to help and protect others. We want to avoid posts that have in or out group messages, and also those that are stigmatizing or that have guilt and shame as part of the message. And I think really, when we think about, again, the antidotes to moral injury, to guilt, to shame, and with PTSD, it often is not fear that drives post-traumatic stress disorder, it's guilt and it's shame. And it's an inability to feel positive emotions. So when people have depression and when they have PTSD, it's really powerful to be able to say to them, I recognize it's not just that you feel sad or that you feel disconnected, but also that you can't experience positive emotions, that you've lost that ability to feel happiness or joy, that you've lost that ability to connect socially. And that's part of the loss in this illness, and it's part of what we need to tackle together. It's not just helping with the sadness or the fear, but also helping you to get back some of those really positive emotions like happiness or connection or joy, bringing that back online too. I think for all of us in this situation, we need to acknowledge that we're human. And that can be really hard to do because even the public language around this is that healthcare workers are superheroes right now. And there's no doubt that healthcare workers are, but we're also human. And I know last night I went in at 8 and I was in the hospital still around 9 o'clock. And I actually wrote to someone and said, I can't do everything that I need to do today. I just can't. I can't stay until midnight tonight again. I think that's part of acknowledging who we are, that we're humans, and we do also have needs. I think with all of us as well, we have a capacity for leadership. So we have knowledge and experience and learning through our profession and through our connections, and we can bring some of that experience to others to help provide leadership around decision making, for example, around pandemic pay. We have that capacity within us for leadership, and we need to use it. Again, encouraging for ourselves self-compassion. So when I speak to people who are struggling with PTSD and depression, and they say, you know, I'm not going to take that time for myself. I'm not going to take a break. I'm so angry at myself. I say, well, if that was your child or your daughter, or your mother, your father, your husband, what would you say to them? Would you have self-compassion and empathy for them? Then how do we use that same self-compassion and empathy for ourselves? How do we turn that upon ourselves? And sometimes the way to do that is to think about what you would do for someone else that you loved or cared about, and then to bring that same sort of self-love to ourselves. I think we also do need, at times, we have to dig deep to feel self-compassion for others as well. So others who we feel maybe haven't made the right decision, to try to have some form of self-compassion for them as well. Right now, nothing I think could be more important than seeking social or peer support. So again, reaching out to others, to our colleagues, to our friends, to our families. And you know, it is important to acknowledge, this is a point that's often lost, that when people are talking about some of the difficult challenges that they've had, about moral injury, about betrayal, sometimes they actually don't want to make eye contact. People who are feeling you know, guilt or sadness, often they want to look away and not look you directly in the eye when they're speaking. And I think that's okay. We need to acknowledge that and be aware of that, and not try to necessarily bring people back to us face to face, but really allow them the space to tell their stories in the way that they're most comfortable with. Another way of doing this too is if people are having difficulty self-disclosing face to face, or by our new way of Zooming or connecting over the internet, sometimes it's helpful to let people talk on the phone, where they may feel less judged when they have the opportunity to speak without someone seeing them. Really important as well to acknowledge that seeking professional help is not a sign of weakness, instead it's a sign of strength. So you are a superhero when you reach out to others and ask for help. That is modeling for your children, for your colleagues, and for everyone else around you, that seeking help is not weakness, it is strength. You are a hero when you do that. And this is a mental health continuum model that's been adopted by the military. I'm going to send these slides out because I recognize we're at the end of our time. But what this talks about is the distinction between being healthy, reacting to a situation within the moment, being injured and needing to reach out for peer support, reach out for help, and being ill. When we need help right in this moment, we need to get ourselves out of this situation and seek help. And these examples are really nicely captured here, and I'm going to send that out as a PDF to the community. So just coming back to that personalized approach, what are your own warning signs? So I know, for example, when I start to feel irritable, I am not an irritable person. And when I do, I know I'm reaching my breaking point. So knowing what your own personal warning signs are. Thinking again about what has worked for you in the past. What are the strategies and the techniques that have helped you previously? And I think a few lessons that I've learned from some of the work that I've done with the public safety personnel community is that the consequences are really important. So when someone fears that coming forward could cause them to lose their license, with police that said their gun is taken away when they disclose mental health concerns, we may need to make sure that people know it's safe to come forward, that they're going to have the help and support that they need, and that the consequences won't be so dire as they might perceive or imagine them to be. The first principle in trauma care is to witness and to believe. So when someone tells you about the difficulties that they're facing, when they tell you about a traumatic situation, we bear witness to that experience. We listen with compassion and empathy, and we believe what the person is saying. And then hopefully we're also equipped to take action and to provide assistance. And if we are delegated, for example, as a peer support person or as a mental health provider, we need to know what the next steps are. So we as individuals who may be struggling with mental health illness or mental health difficulties rather, need to know who to go to. And when we provide that information to someone, the receiver, they need to know what the next steps are to assess that individual or to help that individual to get help. So I want to conclude by saying, remembering that it's not all on us as individuals, that we stand together. And I want to thank you again for the opportunity to give this talk. So thank you so much. And that's the end.
Great, thanks. Thank you, Margaret. That's fantastic. We are a bit over time. I do have one question in the question box. So I'd like to ask that one question and let everybody know this has been recorded. So the question is there a process of debriefing post-COVID-19 that can be implemented to assist healthcare professionals, or should we just, is it more advantageous to continually debrief, and who should facilitate it?
An excellent question. So one thing that we know that in the past debriefings have been done sometimes with individuals from different groups. And so, for example, when fire and police debrief together, that can actually be quite difficult because they have different experiences. I think it's important for us to debrief in this situation within our own groups, so for example, within the respiratory therapy community, and then to also go out to other groups. I think continuously debriefing is important as long as it's handled in the right way without stigmatizing or blame, which I know will not happen here, but it has happened in other groups in the past. And yeah, I think that and when this is all over, we are going to have to do a real psychological autopsy of what's happened, what harm was prevented, what decisions that we made resulted in less harm or prevented a greater harm, but did have consequences that are difficult to live with. So yeah, I think there really is a place for coming together as a community, both within our professions, then together as a healthcare community. And I think ideally, certainly for your group, it would be ideal if someone from the community could lead that. Other people can be brought in, but I think the shared experience that you have, I think it's far better for it to be someone from within the community doing that. I hope that's helpful.
Yeah, thank you. So that's great, thanks. Anyway, sorry to the audience, we're a bit over time, so we will have to wrap it up. But Margaret, we may ask you to come back because that was a ton of information, and like on reflection now, I'm thinking we probably should have done it in 2 pieces. But no, it's okay. I think there's a ton of interest in this topic. People have obviously stayed on the webinar. They're very, very interested. So we may ask you to come back in a couple of weeks, and especially as things develop through this situation with COVID, there'll be more, I think, around the mental wellness and mental health of our providers, including respiratory therapists. So Fatima, I'll leave it to you to wrap it up and say thanks.
Yes, thank you very much for your time, Margaret. It was very informative. I so look forward to working with you on this project. Yes, this is fantastic. I look forward to you sharing that PDF as well. Yeah, very good. Thanks.
Thanks so much, everyone.
Right. Thank you so much. Okay, thanks. Bye-bye.
Bye.